Hey, my name's Matt Lawless. I am an orthopedic surgeon. I did my residency here at Wright State and then went off and did a fellowship in knee surgery in Indianapolis. I've been in practice at Wright State for almost 14 years. My practice is probably 95% now knees. I treat athletes, I treat adults with knee arthritis, the whole spectrum. Tonight we're going to talk about knee arthritis and eventually we'll get to knee arthroplasty. We'll keep it informal. You guys have any questions, don't hesitate to interrupt or interject. The questions you have are probably questions on everyone's mind. When I see knee arthritic patients, I get a lot of very similar questions. So knee arthritis is the most common form of arthritis. It's the most common type of knee pain. It's also called degenerative joint disease. It's also called wear and tear arthritis. It presents as the knee becomes more swollen and more painful, and it starts to get stiff as the cartilage in your knee starts wearing away. Rarely does it occur before age 50. The prevalence, so if you get to live to be over 75, there's a 30% chance you'll get knee arthritis. It can involve the medial compartment, which is the inside of your knee. It can involve the lateral compartment, which is the outside of your knee, or it can involve your patellofemoral joint, which is the front of your knee. It usually worsens slowly with time, but it can be rather mild for a long time and then all of a sudden have a twisting injury, step off a curb wrong, and then all of a sudden have bad pain. So how do we diagnose knee arthritis? Usually by a history. It's usually steadily worsening knee pain, more swelling, more stiffness. Exams usually have a swollen knee. People with arthritis find that their knee gets bigger with time. It also starts getting stiff. The biggest diagnostic tool I use are standing x-rays. So I get an x-ray of people's knees. I usually get both knees on one film so I can see one side versus the other, and I make sure they're weight-bearing or standing. A lot of people ask about MRIs for knee arthritis. Typically, MRIs offer very little added help, almost no added help than a regular weight-bearing knee x-ray. So here's what a normal knee x-ray looks like. Hey. You can see that this black space here is cartilage. So this is a pretty healthy-looking knee x-ray. This is a side view. So back here, when we talked about the medial compartment, that's the inside part of your knee. You can see there's a joint space there. This is the outside or lateral compartment. And here's a side view of your knee. So that's your kneecap up front. This is the back of your knee. And there's your knee right there. And you can see that nice, healthy black space there. So this is an arthritic knee. You can see on this, there's no more cartilage. And again, the black stuff there is the cartilage. So there's no cartilage there. Side view, again, no cartilage. You're starting to get big spurs, big osteophytes. So comparison x-ray, pretty healthy looking knee here with well-maintained joint space, arthritic knee here. Questions, comments? Yes? Great question. Ankle problems related to knees. This is arthritic. It's kind of a long-winded answer here, but this is an arthritic knee that involves both the inside and the outside. A lot of times, arthritic knees will involve just the inside or just the outside. In that case, your knee will start getting crooked one way or another, and that will change the dynamic of how your ankle works because your knee's no longer straight. So that can cause some ankle problems. The other issue could be if you're limping. A lot of people with knee arthritis end up limping, and that can cause ankle problems also. Yes?
Where does the pain usually present itself? In the knee, above, below? Right?
Typically, it's diffusely throughout your knee. Most people will point to the front. Some will point a little bit above. Some will point a little bit below. occasionally it'll be down, radiating down, but it's almost always in the knee, either a little bit up, a little bit down, but generally almost always the knee. If it's anywhere else, then it's usually hip, back, something else. Other question? Yes?
So the knees would have an effect on an arthritic back?
Oh, absolutely. Well, knees would have an effect on an arthritic back once you started limping. So as you get up and start limping a little bit, then your back mechanics are off. So yes, that will definitely have an influence on your back. Yes?
You see football players with one of those scissor braces on their knee. I know the Ohio State entire line, offensive and defensive, wears those things. Are
Yes.
they so much to prevent the knee getting destroyed if you get hit from the side, or are they necessary?
Great question. I will answer that and then skip the part of the slide where we get to that. So he was asking about knee bracing, and he actually mentioned Ohio State. So knee bracing for Ohio State is different than knee bracing for arthritis. Knee bracing for Ohio State is they did a study trying to see if knee bracing would prevent knee injuries. And what they found is that in interior linemen, so that's what you said, the offense and defense linemen, so it's only the linemen, bracing will prevent MCL injuries. So if you're looking at your knee, this is the outside, this is the inside, this is your MCL. So mostly the Big Ten, the interior linemen wear those knee braces to prevent MCL injuries. Knee bracing for arthritis gets back to whether your leg's crooked or not. Again, I said this guy, or this person here has pretty normal, you can see the alignment of the knee is pretty normal. It doesn't involve one side or the other. If it involves one side or the other, then you can get a fancy $800, $1,200 brace that will apply force to help offload it. It's called an offloading brace. So if you have arthritis that just involves the inside of your knee, just the inside of your knee would be like this when you stand up because all the cartilage is gone. So the brace would help kind of muster it over this way. I don't use those braces very much because they're not very easily tolerated. People don't like wearing them because they push on the knee. You got to have a pretty skinny knee for it to work well. So when I brace an arthritic knee, usually what I do is just get an over-the-counter neoprene sleeve, like at a sporting goods store or at a drugstore. Long enough answer? Perfect. Other questions? Risk factors for arthritis. Probably the most important risk factors are genetic predisposition. If your parents had it, your grandparents had it, aunts, uncles, someone in your family had it, then you're probably at much higher risk to get it as well. Obesity, people that have a higher BMI than they should are also at risk for knee arthritis. Back to your athletic question again, joint trauma. People that have had ACL tears, especially with meniscus or cartilage trauma, are at high risk for developing arthritis down the road. This is a big slide that says what we just said. People that kneel a lot at work have a little higher risk of arthritis. Elite athletes do too. I hear a lot of people tell me that they played high school football and whatnot, and usually that's not a risk factor. Jogging, under 40 miles or so a week, usually not a risk factor. It's the elite athletes, the people that are playing at a professional level, that are a little higher risk for knee arthritis. Osteoarthritis. Osteoarthritis is the most common form of arthritis. That's the wear and tear of the cartilage. Almost everybody has osteoarthritis. The other kind of arthritis is like inflammatory arthritis, like rheumatoid arthritis, gouty arthritis, those sort of things. If anyone here has arthritis, it's almost certainly osteoarthritis, which is just wear and tear of the cartilage. So people with varus knees, valgus knees are a little higher risk for progression of their arthritis. The good news is losing weight helps symptoms of knee arthritis. So people that are heavy, that if they can manage to lose weight, that usually means that their symptoms of their knee will probably lessen somewhat. Yes?
What are varus and valgus?
A varus knee is where the inside, the most typical wear pattern we see in osteoarthritis or regular arthritis is medial compartment wear. So the inside of your knee cartilage wears out. So as that wears out, the bones get closer together on the inside. So if your leg is straight, as you get varus arthritis, your leg starts tipping like that. Valgus is the opposite. Valgus arthritis is much less common than varus arthritis. So when we see people with arthritis, how do we treat them? Almost everyone I see gets some form of physical therapy. Usually people have had symptoms a long time. They've gotten very deconditioned. They've usually gotten stiff. They've gotten weak. I send them to therapy to get their motion back, and I get their strength back. It helps improve the symptoms. If we do end up doing surgery on down the road, the stronger you are ahead of time, the better you'll be for the rehab afterwards. So physical therapy, again, is essentially to help reestablish range of motion. People start getting stiff. They can't straighten their leg as much as they could before. They can't bend their knee as much as before. So the first goal of therapy is to help get your motion back and then to work on strengthening. Regular low-impact exercise is helpful. Biking, elliptical machine, even walking if you're not limping can be helpful. Bracing we already discussed. The offloading braces, again, I don't use it very often. The most common thing I use is just an over-the-counter neoprene sleeve. A cane does offer pain relief. So the cane is used to help offset the weight going through your painful knee. So if I have a right knee that's arthritic, I'll use a cane in my left hand. I'll put the cane down at the same time I put my right heel down. It'll help share the load. The cane in my arm helps offset some of the weight going through my painful right knee. Canes do help with some of the pain. So I hear a lot of talk about ultrasound working, TENS units working, magnets, low-level laser therapy. Most of that stuff has not been scientifically proven to help. Most of it's not harmful, but there's almost no evidence that any of that stuff makes any difference at all. What medicines can you take? I hear this question very frequently about glucosamine and chondroitin sulfate. Most of the studies show that it should offer some pain relief, similar to an anti-inflammatory, but so far we have no medicine that's going to stop the progression of arthritis. Once you start getting arthritis, it's usually a progressive disease. It keeps getting worse and worse. And even chondroitin sulfate or anything else is only to help relieve the symptoms. It's not going to help put cartilage back on your worn-out knee. Tylenol is a very safe medicine to use for the pain of knee arthritis. Anti-inflammatories seem to work better than Tylenol. You can take them together. A lot of times I'll have people take Tylenol and Aleve. I like Aleve because it's generic, it's cheap. It's only 2 pills versus Motrin's 4 pills. So it's just something that has to be watched for a long time. It can affect your kidneys if you take it for a long time. And about 2 to 4% of chronic users will get GI issues, bleeds in their stomach. Intra-articular injections I use quite frequently. What an intra-articular injection means is that we put a needle into your knee and put medicine into it. Most commonly we use steroids. So we use a little bit of a numbing agent like Marcaine with a steroid, and we put that right into your knee. It's very effective in mild to moderate arthritis. People frequently ask me how long will it work. Variable. Usually in mild arthritis, it will last weeks, months. As the arthritis gets worse, the shots become much less effective and may only last days. Do you have another question? No.
Can you have the steroid injection? How long can that, I've had a couple of them, how long can that,
So how
can I do
long?
that for a couple of years, or?
How long can you keep getting steroid injections? I usually tell people, I ask that very frequently. I suggest hopefully it'll last at least 3 months, and then I'm willing to give it every 3 months as long as it's working. I've had people I've injected for years. I've had people I inject once or twice, and they say, I don't want it anymore. I'm ready for something else.
How painful are these injections?
So how painful are the injections? Most people, when I'm finished, say, oh, is that it?
Yeah, it's not.
Yeah. Yeah, she up here, she's had a couple of them. She said it's not much. And it's usually not a big deal. Most people literally say, oh, is that it? And they're like, yeah. It usually acts right away. So about 80-90% of the people feel better right away by the time they're walking out of the office. It's usually something we just do in the office. And it takes just a minute to do. There's a lot of advertisement on Synvisc. Synvisc is one of many different kinds of hyaluronic acids. Hyaluronic acids is one of the, essentially it's a thick liquid that we put into arthritic knees. We put it in the same way we put steroids in, where it's an injection that goes right into your knee. When it first came out, it was a series. We'd have to give one a week for from 3 to 5 weeks. Last couple years or so, there's been Synvisc 1, and some of the other brands also have just one shot, where instead of a series of them, it's just one shot. You come in, you get one shot. I usually start with cortisone because cortisone's a heck of a lot cheaper. You can usually get cortisone shot for about $90. This stuff usually costs $800, $1,000 to do. So insurance needs to approve one of these things before it gets doled out. Yes?
Is Euflexa part of that family?
Yes. Euflexa is also part of the hyaluronic acid. Yeah, there's multiple ones. Yeah. Yes?
So if Synvisc wasn't successful, it didn't alleviate the pain, should you try a steroid? Or is that indicative that
So if one of these things doesn't work, will steroids work? If you hadn't had steroids, a lot of it depends. So if I saw your x-ray and your x-ray looked like that x-ray we saw already, I would say it's probably pretty bad and nothing we do is going to help short of surgery. Which we'll get to shortly. Yes?
how effective is the Synvisc in comparison with steroids?
So both Synvisc and steroids are very effective in mild to moderate arthritis. If I have someone with moderate arthritis that's young, then if they only get a couple months of relief from the cortisone, then I'll try one of these. It seems to last a little bit longer than the cortisone. So when I see somebody, this is effectively what I go through. I have them start in physical therapy. I like people to do a home program. So a lot of times I'll have them go to a therapist once or twice, learn what exercises to do at home, and then do them at home. Ice with activity. Ice simply helps with the pain. So when your knee's sore, if you put ice on it, usually tends to feel better. Tylenol, often with an anti-inflammatory. And then once those stop working, talk about intra-articular injections such as cortisone or Synvisc or something. Nothing has been proven to be any better than anything else. So Euflexa hasn't been shown to be any better than Synvisc, hasn't been shown to be any better than Gel 1. So all the hyaluronic acids and all the cortisones are all about the same. So once all that stuff fails, then what do we do? So surgery is where we go to next. A lot of people ask me about arthroscopy. Arthroscopy is a surgery where we make some very small cuts in the front of your knee. We go in with a camera, we go in with water, we clean up your cartilage, clean up the meniscus. clean up any debris in your knee. It works okay in mild arthritis. It works good if there's loose bodies, if there's other things in your knee. Unfortunately, like the injections, the arthroscopy is inversely proportional to the amount of arthritis. As the arthritis gets worse, a scope's not going to help. So the arthritis pretty much trumps meniscus tears and everything else as the arthritis gets worse. In other words, scopes don't work much once the arthritis gets bad. Osteotomies, we'll kind of skip over. Unicompartment replacements. These are when we replace just one part of your knee. So before we talked about getting arthritis usually in the medial aspect of your knee. If your arthritis is isolated to that, then we can do a partial knee replacement where we only replace the inside part of your knee. So this is a lady I saw that has pretty bad medial compartment arthritis. The outside doesn't look too bad. Side view. So we replaced just the inside of her knee. What a knee replacement does, you can see here we effectively have trimmed off the tip of the worn off bone, put a metal cap on, and did the same thing to the tibia. So we took this x-ray here where all the worn out cartilage and bone is on both sides of the knee, trimmed it off, put a metal cap on, put a metal cap on here, and there's a plastic piece that sits right in there. So this is a uni replacement or a partial knee replacement. You can do partial knees for here, or even for your patellofemoral joint, but by far it's more common to do it on the inside or medial part of your knee. So total knees. When the arthritis involves more than one compartment, then we talk about doing total knee replacements. People ask, how long is a total knee going to last? At 10 years, 90 to 95% of total knees are still in. At 20 years, 70 to 75% are still in. There's some newer plastics out there that probably will last even longer and probably have a better survival rate than these numbers. Yes?
Do the partials have a longer life than total replacements?
Great question. She asked, do partials last longer than totals? The 20-year survival rate for a total is about 75%. For a partial, it's about 85%. So they do seem to last longer. If they fail, they usually fail sooner, though. So if a partial is not going to work, it usually fails within the first few years. Once you get outside of the first few years, then it will probably keep going for quite a while.
Is that because usually there's more arthritis presenting outside that area?
Great question. I don't think anyone has a real good answer for that. A lot of reasons why.
What was the question?
So why do total knees not last quite as long as partial knees? And it probably has to do with the amount of plastic. The plastic wear is what makes the knee fail. So eventually, if you're fortunate to live long enough and put enough cycles on your knee, this plastic piece will wear out. That plastic piece wearing out will eventually make all this stuff loosen. So the 15% or the 25% of total knees that fail at 20 years, most of the times fail because they got loose because the plastic started wearing out. Yes?
The white parts, are those also plastic?
The white part's metal.
That's metal, okay.
Yes.
The plastic is in between.
The plastic is in between there. Yeah, that black space there is plastic. The white part is metal. And you can even see this little white part right there underneath the metal is cement. And that's how we hold the metal to the bone is with cement. Yes? So when a total knee fails, I got it now. When a total knee fails, yes, we take everything out and put a new set of total knee in. Yes.
Partial, is it possible just to replace the plastic, or do you have to replace both?
So great question. So in my practice, I have people follow up. So I see people, he asked, is it possible to replace the plastic if you can catch the plastic wear soon enough? So I see people in the office every couple years after I do a knee replacement on them and get screening x-rays. So it's possible to pick up this piece wearing out before this gets loose. And in that case, yes, you just change the plastic out, which is a smaller operation than changing everything out. And if it's smaller for me, then it's smaller for whoever else is getting it. So this is a person you can see with arthritis involving the medial compartment, the lateral compartment, also with some kneecap arthritis. So that's an x-ray of a total knee. And you can see the metal on this one goes all the way across and all the way across here. So a side view is it's a metal cap and a metal cap, again, just like the partial knee, with, again, the black piece is a plastic piece. So effectively, it looks like this. So what we do with the surgery is we keep the ligaments intact, trim off the worn out bone, put a metal cap on it with a plastic piece, and then put a metal cap on the tip of your femur like that. So instead of the worn out bone on the worn out bone, you now have metal on plastic.
On the percentages you had, for example, 75% failure within about 20 years. On activities, let's say like ballroom dance, where you do a lot of pivoting, turning,
Yes.
how much does that skew the percentage down, or does it?
So how much does activity skew the survival rates of a total knee? People under 50 seem to wear their knees out quicker. So those numbers are very greatly skewed for someone that's 45. Total knees are designed for walking, hiking, bike riding, dancing. They're not designed for running, jogging, high-impact activities. But they're very much designed for ballroom dancing. I would encourage people to ballroom dance. I would encourage people to golf, to hike, walk, whatever.
So that would not put somebody at higher risk?
Ballroom dancing would not put someone at higher risk for revision or earlier wear of their knee. Yes?
Since we're on the topic, what about tennis and skiing?
So I have patients skiing. The thing about knee arthritis is most people, by the time they get to the point that they need knee replacement surgery, they've honed their life down pretty much. So they're not doing the crazy skiing that they did when they were 30 and 40 years old. Is it safe to ski? Absolutely. What was the other thing you said? Tennis. Tennis. Doubles tennis, yes, certainly doubles tennis. Singles tennis, a little bit more questionable. On a rare occasion, singles, but certainly doubles tennis, yes. Yes?
Can you do these types of knee replacement surgeries when there's been an injury that's been repaired previously?
So can you do knee replacements after another failed surgery? Certainly. Yeah, so like an ACL surgery that was done 20 years ago, can you do a total knee afterwards? Yes.
What about I have a steel rod in my leg? It runs from my knee to my ankle.
Yeah, so a steel rod running from your knee to your ankle is probably for a tibia fracture. I use it usually in people that have had like a nail in here. I usually use a different kind of tibia here, so I work around it, or you can take the nail out. There's now computer systems that make jigs for you, so you can avoid stemming in here at all. So there's, yeah, that's not, hardware around a knee is usually not an issue. Yes?
Maybe it's before its time, but the question is, what's the state of advancement in terms of regenerating cartilage? In other words, why can't you take a person's tissue and grow cartilage in a petri dish and then that it?
So why can't you grow cartilage and effectively get rid of knee arthritis? The cartilage that we are doing is usually isolated lesions. So an athlete tears their ACL, at the same time they tear their ACL, they knock off a little piece of their femur. Yes, there's things we can do for a little piece. When it affects the whole knee, like this, there's just no way that we currently have, or nothing even on the horizon that we have, that can make cartilage grow in there. It's just too diffuse and too much.
So you can't go to the lab and insert it there?
No.
I've heard about artificial cartilage being messed around with vertebrae. Is there anything in the possible realm of that?
So most of the again, what we can do for smaller lesions is do a surgery, take some cells, send it to a lab, grow it up, and then implant it. And it works well for a small lesion. You know, if you just had a little lesion right here, it would work. But when it's so diffuse, so far in the knees, we don't have any. I mean, yeah, I mean, there's gobs of people working on that because that's a huge. They, about 25 years ago, started limiting the amount of orthopedic surgeons they were training, thinking that, well, boy, we're going to have this osteoarthritis thing licked here soon, and so we don't have to worry about it. But still, we're no closer than we are, and people are getting older with more worn-out joints. So.
Why not just metal on metal? Why do you need a thermoplastic?
Because the debris from metal on metal is too much. The debris from metal on plastic is almost nothing. That's why metal on metal didn't work. And so far, the best, and they've tried all sorts of things, and so far, our best weight-bearing joints are metal and plastic. Yes?
Compared to an ACL recovery period, what's the total knee replacement recovery period like?
ACL surgery and total knee replacement, what are the differences? I rehab them the exact same. That's a harder question to answer because most ACL patients are pretty high active. Most total knee patients are less active. Their performance afterwards, ACLs probably go a little bit quicker, but they're probably a little bit better going into surgery. So vague answer to a hard question, but yeah. Very similar rehab cell.
6-month recovery or 1-year recovery?
So how long does it take to recover from knee replacement surgery? And I'll just take you through typically what I do, and we'll get to all that stuff there. So when I finally get somebody that's failed conservative therapy, injections, therapy, whatever, and we decide that it's time for a total knee, then the way I do it is the day of surgery, they usually get a spinal anesthetic, a needle in the back, makes the legs numb, take you into surgery. The surgery itself takes about an hour to do my part of the surgery. There's a little bit of setup and breakdown afterwards. After surgery, you go into the recovery room for about an hour and a half, then up to the floor. On the floor, the night of surgery, the therapist comes by, starts you on your exercises. Starts you extending, starts you lifting, starts you bending, even stands you up. Everyone starts on a walker. So the day of surgery, even will take some few steps in your walker. The next day that continues. Our length of stay is about 1.9 days now. So some people go home at 1 day, some people go home at 2 days. It's usually in the 1 to 2 day range that people are going home from the hospital now. The first couple weeks, I have a therapist come to your home. At the home, they go through the exercises, make sure you're doing them okay, make sure you're safe on the walker, make sure you're getting around okay. Most people get off a walker by 3 to 6 weeks. Most people with ACL surgery get off their crutches 1 to 2 weeks.
Did you ever use passive motion machines?
Excellent question. Do I ever use passive motion machines? So, long story, but yes, when I did my fellowship, we were all about the passive motion machines. And one day a therapist said, you know what, these passive motion machines, are they any good? So I'm like, I don't care, just turn them off. I just want the elevation. Because after a knee surgery, your knee is going to swell. One of the best ways to keep the swelling down is to keep it elevated. So after knee replacement surgery, I elevate people's knees right away. We came up with a pillow to use instead of the CPM. So then we compared what's doing better, our CPM or our pillow. And our pillows were doing much better. So we got rid of using the CPM machine because our numbers with the pillow were so much better than they were with this passive motion machine. Yes?
Do you still use the little ice machine?
Yeah, ice is a good modality for soreness. So afterwards, I usually put people on 4 different pain meds as well as ice, yes. Yes?
Is there a weight limit? In other words, if you're more than so many pounds, we can't do that surgery on you?
There's no weight limit.
Rules of thumb.
No.
Okay.
They have done studies to see, do people that weigh more wear out their knees quicker? Because you'd think if running wears your knees out quicker, certainly if you weigh more, you're going to wear your knees out quicker. But most of those studies show that there's really no difference in the wear rates of a skinny person versus a heavy person. And it's probably because a skinny person is skinny because they take more steps than the heavy person that takes less steps, but just conjecture. Yes?
What's the drugs you use?
So after surgery, I use Percocet, Lyrica, Toradol, and Ultram. I also use an adductor block. So a lot of the nerves that go to your knee come down the medial side of your thigh like this. So in the recovery room, after we're finished with our work, the anesthesiologist takes an ultrasound machine and puts a catheter right on top of that nerve with a pain ball that's filled up with Marcaine. So the Marcaine drips on the nerve to knock the pain receptors out while you're healing. And that usually stays in for about 5 days. Yes?
Is there any risk to the perineal nerve?
So what risks are there to the perineal nerve? So the perineal nerve is a nerve that runs out here. It's the one that helps lift the foot up in the air, so when you walk, you don't drag your toes or don't slap your foot. The perineal nerve is most commonly injured when you have a valgus knee and you straighten it out. You can put too much stress on the nerve. Very, very, very rare. Other questions? Yes.
So how do folks decide when it's their time to have surgery? If they're at a pretty severe arthritis stage, if they can't do the activities that they normally have done like sports, but yet they're moving into the age where, as you said, they're not expected as much, but
Yeah.
there's a longing for that.
So when is it time to do a total knee replacement is effectively, and that's, again, a very common question. People usually know when they're ready for a knee replacement. They get frustrated with walking in the grocery store and then coming home and having to lay down because their knees hurt so bad. They get frustrated because their knees wake them up at night. Usually people get to the end of their rope and they know that it's time to have it done. I usually tell people, you know, once it's to the point where it's keeping you from doing things you want to do or waking you up at night, then it's probably time to. Yes?
Have you found any correlation between the weather and advancement in arthritis?
Yes, people with arthritis, so with advancement of the arthritis, no. Do people with arthritis feel different on different days depending on the barometric pressure? Yes. A lot of people with arthritis will come in and say, I know it's going to rain tomorrow because my knees are starting to ache. Oh. Yes?
Is there a disadvantage to putting off the knee replacement as far as not being as successful?
So is there a disadvantage to putting off a knee replacement? Technically, no. You know, we can do a knee replacement on whatever is brought in. The longer you've limped, the stiffer you are, the weaker you are, makes the rehab a little bit more difficult. Correcting a limp that you've had for years can be a little bit more difficult. But technically, it might take us a little longer because we have to do a few extra things, but there's no. Yes?
After the knee surgery, we have friends that have no problem whatsoever, and we've had other friends that they've had a numbness in their knee, like a block, maybe 3 inches by 3 inches. What causes that, and will that ever go away?
So, some people have numbness after surgery. Will that go away? So, when we do the surgery, effectively we're making an incision down the front of the knee. And when we do that, we cut through some of the tiny little bitty nerves there. So everybody is numb around their incision initially. It usually fills in with time. Sometimes you're left with a little strip of numbness around the incision, but usually gets better with time, usually a year or so, and most of it fills in. Is there any disadvantage to having it besides it feels weird? No. I mean, it's not going to cause any damage by being numb, besides it'll feel a little weird. Yes?
I've had people tell me that even though they had a full knee replacement, they sometimes say, gee, I wish I hadn't done it because my knees still hurt. Why would their knees still hurt if they've been replaced?
Great question. Why do knees hurt after knee replacements? That's a difficult question to answer. The indications for surgery might have been it. I've seen some knees that have been done in people that don't have bad arthritis. People that do best with knee replacement surgeries are people with bad arthritis. If you did a knee replacement on someone with just a little bit of arthritis, they're not going to do near as well as far as a pain relief than someone with a lot of arthritis. There is a very, very, very small subset of people that probably have an allergy to the metal. And that can sometimes cause soreness in their knee afterwards. Very rare. I think I've seen it once. I took that person and switched out their metal to a different kind of knee, and their pain went away.
What kind of metal is that?
Cobalt and chrome is the highest metal stuff. There's nickel and a bunch of trace metals in there also, but this is mostly cobalt and chrome.
Are there any of them made out of titanium?
There are some made out of titanium. It's not as hard of a metal, so this nice, smooth, hard metal decreases wear rates. So titanium is not as ideal as a metal to use than cobalt and chrome. Yes?
Is that the real thing? That's
Yes.
what you put-
Yes.
How heavy is that?
50 pounds. So it's heavier to get sick, but it's not, yeah.
Will that set off the modern airport screening equipment?
So most people after surgery get a card in the mail saying you have a total knee, and that's to take for the airport or the courthouse when you go through, because a lot of times it will set off it. Yes. Especially with the heightened. Yes. Yes.
You ever had anyone do both knees at the same time?
Not since this morning.
So is the recovery rate the same?
So when to do bilateral total knees or both knees at once. People that have both knees done at once, if someone comes in with both knees arthritic, I'll make them ask me first, because I won't bring it up, because they has to be someone that wants to have it done. And if they do it, then the rehab, yes, usually goes smoothly. Yeah. Same amount of pain meds, same amount of everything. Yeah. Yeah.
But don't you need one good knee to go like up and down stairs? You're supposed to go up when you're good, come down when you're bad. How would you do
So before you go home from the hospital, they teach you how to get up and down stairs. Yes, it's a little bit more difficult to do stairs, but I'd almost prefer it because it forces you to get rid of your limp. Because if you have a good knee and a bad knee, then you can still drag your healing leg along with your other knee. So if I had my druthers, I would do bilaterals more frequently because of the rehab. If one knee's not as bad as the other, then I probably wouldn't. If they were both pretty much end stage, then yes. It depends on the severity. Yes?
Can you kneel on?
So can you kneel on a total knee afterwards? Yes. The incision a lot of times will preclude people from doing it initially, but yeah. Eventually you can kneel on it, yes. Eventually is variable from 2 months to a year or so. Yeah. Yes?
These come in different sizes.
Yes, they come in a ton of different sizes. The system I use predominantly has 24 femoral sizes. Yes?
How long is the incision and how prominent is the scar afterwards?
The incision usually runs from right above the knee to right below the knee. Most scarring is genetic. So we use all the sutures underneath the skin, so we don't take sutures out or staples out afterwards. It's all underneath the skin. Yes?
Does being outdoors in severe cold bother?
I've had a couple people say that being outside in the severe cold bothers it a little bit initially. The first winter, yes, but the second winter, no. That's something that usually gets better. And it's very rare that someone says that. Yes?
Are you likely to be able to do stairs after you have knee surgery?
Once you're rehabbed, yes. Yes. Because it gets rid of that pain you get when you're climbing stairs. So, yeah.
Is there any advantage or disadvantage to treating or not treating when you're dealing with arthritis?
Is there any advantage or disadvantage to treating or not treating arthritis? As long as you're not limping and as long as it doesn't keep you from doing things you want to do or should be doing, like exercise, walking, those sort of things, then there's no advantage to treating it. Once it keeps you from doing things you should be doing or want to be doing or interfering with your life, then you should start treating it somehow, be that therapy, aspirin, whatever.
If you have both hip and knee problems, does one take priority over the other?
So if you have both hip and knee problems, what do you address first? The most symptomatic. And it depends on how stiff they are. If your hip is really stiff, I would send you to my partner and have hip surgery first, get your hip moving better, and then do your knee. Both being equal. Yes?
I had arthroscopic surgery on my right knee.
Yes.
They gave me a series of exercises to do.
Yes.
3 years ago, my mother suffered a couple of mild strokes. She was in a nursing home for 7 weeks for therapy, and they were doing the exact same exercises
Yes.
with her. I played home nurse after she got home. Would there be an advantage, assuming that your insurance policy would do it, of having the rehab at least a week or 2 or 3 maybe in a nursing home where they have physical therapy right there on the site?
So is therapy in a rehab center like a nursing home good after a knee replacement? My short answer is no. I much rather people go home. The therapists that go to your home, I know. I know I can hold them accountable. I know the people that run it. And so if something goes amok, I get a text, I get a phone call, I learn. People that go to a nursing home, they go into this black box of care that is sometimes good, well, hardly ever good, sometimes average, sometimes bad, and then they come back at 2 weeks. They're almost inevitably worse off than the people that went home. So my druthers are to not rehab at a nursing home. Can nursing homes work and do okay? Yes. But there's certainly no advantage to it. It would seem on the outside, yes, but no, Yes?
What's the average physical therapy time? I mean, if you're cold for 2 weeks,
Oh, wow, that's a great question. What's the average physical therapy time? And I think that's probably dropping as copays are increasing. I don't mind people doing therapy at home, once they're well educated. If you're well educated and well motivated, that's probably better, because then you're probably doing it more frequently and a little harder. So people usually on the average get therapy for the first couple months. Yes?
Is there any advantage to water therapy, using water?
Any advantage to water therapy? Probably not. Water doesn't do much to strengthen your legs. It's a lot better to strengthen your legs on ground where there's gravity, because water eliminates a lot of the gravity, so you don't get a strength in it as much. I mean, it can be a useful adjunct, but there's no significant advantage. Now, with arthritic knees, people can do more in the water because of that lack of gravity. But yes?
You didn't mention Celebrex when you were talking about a lead and all. What's your thinking about Celebrex?
Celebrex, if you ignore all the cardiovascular debates about what's better, Aleve or Celebrex, Celebrex can work quite well. And I usually give people a dose of Celebrex before surgery. But yeah, long term, yes, it's a good, effective anti-inflammatory. Some people find it works better than Aleve or the other medicines. Yes?
Did you address the use of glucosamine?
Yeah, glucosamine, the studies haven't shown that. Most studies show that it does offer a little bit of pain relief, but nothing helps reverse arthritis. So it's not going to put cartilage back on your worn out knee, unfortunately. Yes?
How difficult / painful is the therapy? I know somebody who didn't heal well, and I didn't do the therapy.
How painful is the therapy? Therapy is, the first couple weeks are the roughest. But if you keep the swelling down, and so the way we've designed our rehab protocol after surgery is when you go to the recovery room, you get placed in a pillow that holds your leg up in the air. You get an ice thing on your knee. The therapist works with you, stands you up, straighten, bend. You kind of help assist yourself, and then you go back and elevate more. So you help minimize the amount of swelling in your knee, and I think that's done a lot to help us get better outcomes as far as range of motion and pain scores. Yes?
When you refer to the ice thing on your knee, are you referring to just an ice bag or an actual chilling sleeve with the...
We actually use a chilling sleeve. I mean, it doesn't make any difference. As long as it's cold, it doesn't make any difference.
What's the range of motion that you expect people to get back? And what's the degree, like 120, 130?
Our average discharge numbers from the hospital are probably 118 degrees, I think. So most people leave the hospital at day 1 or day 2 with 118. Depending on your body habitus and how much motion you had ahead of time depends on how much you gain from there or lose from there. So most people probably on the average fall into between 110 and 125 degrees of motion.
I don't quite understand. If 90 goes there, what is 125?
So 90 would be, so if this is straight, 90 would be about right here. So 120 would be about like that.
That's to go home from the hospital.
Correct, and that's what I said. So some people lose a little bit of that, some people gain a little bit of that, some people hold the same.
But after the therapy and all, you should be perfectly flat.
Yeah, you should be flat with about 120 of bending, yes. Yeah. Yeah, flat being straight, yes. Yes.
Somebody was kind enough to drop a log out on 675, which I ran. And in the process, I essentially twitched when I realized that thing wasn't a kid's kickball, it was a piece of wood.
Yes.
And anyhow, The x-ray showed that not only do I have arthritis in my knee, but I've also got scoliosis in my low back, which has never been presented before. I've been told years ago I have to have this replaced. Is it likely that the way I walk has created a scoliosis of the lower spine?
Can knee arthritis cause a curvature of the spine or scoliosis? Probably not. Never say never, but probably not. Yes?
Affect the range of motion, so you would not ever be able to, like, squat, hold, clear up, height.
No, we have people that have 140 degrees of motion. Yeah. So if you go in with a lot of motion, then yeah, you'll come out with a lot of motion. The people that seem to not get 120 or so of motion are people that come in with like 70 degrees of motion. Because there's some people that come in with real bad osteophytes and they can only bend their knee about this far. Those are the people that struggle more with motion afterwards because they're so stiff ahead of time, and it's just that their quads haven't stretched out in that. Yes?
Do you x-ray to see what condition the spine is in before you do knee or?
Typically not. Do I x-ray the spine before knees? No. No. If people complain about their spine and have back problems or radiating leg problems from their back, then I usually refer to my partner that does spine stuff.
Which hospital do you use to do your surgery at?
I usually do most of my surgery at Miami Valley South. I do spend 1 day a week at the VA, and I do some work out there too. But Miami Valley South is where I do most of my day job. Yes?
Going back to the beginning, but you talked about ways to treat arthritis when it's at the beginning. Physical therapy, and someone you mentioned the quads being stiff, and if you strengthen your quads and your hamstrings, is that likely to reduce the pain of osteoporosis?
Yes. So does physical therapy help reduce symptoms of knee arthritis? Yes. In mild arthritis, therapy will do a lot, yes. In moderate arthritis, it'll do some. In severe arthritis, you're probably just getting ready for surgery.
Bone on bone is not going to do a lot.
Correct. Unfortunately, most of our non-operative treatments work well in mild and moderate arthritis. Once you get past that, then there's not much short of surgery. Yes?
Hopefully you're going to avoid them. These last couple of slides that show the apparatus, is that post-op?
Oh, golly, yeah. That was a, well, yeah, that's a case that I inherited. Boy, that's not a knee arthritis case. That's something, we can thank Jen for that one. Thanks, Jen. Yeah, that was I think that person there was a young kid that was in a trauma. That was another, that was a guy that had a terrible run of it, and we did that operation. He actually did quite fine, but yes. Yes?
Okay, as you know that knee surgery is coming, is there any kind of exercises you can do to get your range of motion better?
Any stretching. So like putting a towel around your midfoot and pushing down and pulling up, standing and trying to lock it back. Same thing with bending. Yeah, putting it around your ankle and trying to bend it in.
How about just like doing squats?
That's fine. Yeah, I mean, you can, lean into it and try to, yes. Anything is fine. You're not going to make it worse by stretching it. Yes?
Maybe it's not a fair question and you don't have to answer it. But if you had to get knee surgery done, which surgeon or surgeons in the area would you go to?
So how do you pick a knee surgeon to do your knee replacement? And that's an excellent question. And you should ask your surgeon, no matter what you're going to a surgeon for, how many do you do? How many of these do you do a year? which company do you use, and you want to make sure it's someone that's stuck with 1 or 2 companies so they know exactly the ins and outs of what they're doing, and they want someone that does a high volume being 100 to 200 a year at least.
How many did you use?
Last year I did about 250. Oh, yes?
Which company or companies do you use?
Zimmer. Yes.
They send you Christmas cards every year?
The rep I work with, I enjoy his company. He does a good job, he works hard, and he always has everything we need. Yeah.
Are you familiar with a company called Conformis?
That's a great question. It's gotten a lot of buzz from all those articles in the paper. So Conformis is a company that you go and you get a CT scan, which is a fancy imaging x-ray of your knee. And then they take those images and they send it to the company. The company makes custom cutting blocks that fit right on your arthritic knee to make these cuts, and then you get a custom-sized implant. It's been around probably 2 or 3 years. I don't use it because I don't think it's any better. My patients that I have operated on with Zimmer knees do quite well. I don't get the CT scan because it's a higher dose of irradiation. It's a higher cost. So I usually don't use Conformis because I don't think there's any advantage to using it. In 20 years from now, if they're saying, hey, they're doing at least as good, then I'd say, oh, well, maybe that's reasonable. Sometimes people with hardware in their knee, getting back to someone asked that question before, I do get imaging with Zimmer makes something similar where you can get custom cutting blocks and those sort of things. And sometimes with hardware, it's easier to do that than it is to use our regular cutting jig, so I will do that on a rare occasion. And it'll be a similar thing to Conformis. But I don't see any advantage to Conformis. A lot of the talk of Conformis with better range of motion numbers and shorter length of stay, I would put our numbers against any of them because I'm sure they can't beat them. Yes?
My aunt had double knee replacement. It went bad. I don't know if she had bad parts or something, but they had to do them again. Do you ever find where you get bad parts?
No.
Okay.
Most of there was one kind of part that was wearing out a little quicker in knees 15 years ago, but they don't make that part anymore.
So they had to redo them.
Yeah, that's usually an issue with balancing the knees and with how you treat the ligaments. So it gets back to the whole thing of make sure it's a surgeon that's doing a lot of them. Yeah, I mean, that's a frustrating issue. I mean,
well, the therapy, she had to go through the therapy all again.
right. Yeah. Most complication rates are, the reason I say to go to a high volume person is because the complication rates, like that sort of thing, are much lower in someone that does a frequent number of these. Oh. Yes?
Going back to the exercises, not necessarily like preventative measures, but like when, like before or after any kind of treatment is done for the knees, if there's pain during or after any type of exercises, is that an indication to stop?
After surgery?
I mean, regardless of like time, I guess.
So, is stretching bad if it hurts? Before surgery with an arthritic knee, no. After surgery, no. You're not going to stretch yourself into danger. You will stretch yourself maybe to make it more angry, and the angrier it gets, then the more swelling you're going to get. So you may need to take a little bit longer between exercise sessions to elevate it, ice it, let it settle back down again. But you're not going to, it's almost impossible to overstretch it afterwards.
Any exercise for the most part is beneficial.
Beforehand, yes. Afterwards, again, swelling is an issue. So having someone try to do squats a week out of surgery is probably a bad idea because their knee is going to swell. because it's just been operated on and you're still in the acute inflammatory process. So that's probably not a good idea. But progressing to that is good.
Why do they worry about infection afterwards, that if you're gonna go get your teeth cleaned or anything, you have to take an antibiotic before you even get your teeth cleaned after?
So after surgery, do you have to take antibiotics when you get your teeth cleaned? 10 years ago, I would have said yes. Now I say no. If you're going to have any significant amount of mouth work done, then yes. I would give you, or the dentist usually gives you, an antibiotic to take ahead of time, but not for cleanings.
Why is that?
The thought being that if you're doing a bunch of rooting around in your mouth, then the bacteria in your mouth are getting seeded into your bloodstream, and your bloodstream could take it to a joint, and the joint can get infected that way. Exceptionally rare. And these antibiotics we're giving, we're probably giving a zillion too many antibiotics that don't need to be given. Yes?
You have something I'd call trick knee, where you're just walking down steps, for instance, and it's like the knee gives out.
Yes.
Has that got any relationship to any of this?
Probably. Probably what's happening is you're hitting a spot of your knee where the cartilage is gone and you have some arthritis, so your body's saying, stop doing that, hurts. So that means shutting down your quads.
So is that something it's
Most of the so if you have buckling because of arthritis, that will get better after surgery, yes. Therapy can make that better also if it's just due to deconditioning. You can have buckling just due to being a little weak in your quads. Yes?
Are you saying that once I get my other knee done, that I don't need to take meds every time the dentist looks at me?
Correct.
Oh. Well, I've got an awful lot of amoxicillin.
Yes. Is it going to hurt you to take it? No. Is it going to help you? Probably not. I'm sure there's some, yeah, I mean, if you had a dental procedure and the dentist didn't give you something and something bad happened, could he be medically, legally liable? Potentially. Other questions?
Do you have a different medicine protocol for someone who has cardiac issues and can't take anti-inflammatories a lot?
So if someone has cardiac issues and can't take anti-inflammatories, or people that are allergic to anti-inflammatories, yes, we just drop the NSAID part of our treatment algorithm, so they don't get Celebrex ahead of time, they don't get Toradol post-off, and they don't go home on meloxicam. They still get the Percocet, Ultram, and Lyrica in-house. And so. Yes?
What about if you have a clotting problem?
Bless you.
Do you give the patients
If you have a what?
a clotting problem?
If a clotting problem. So if you have a clotting problem, I usually have you see a hematologist, oncologist ahead of time and get what their recommendations are. So some people that are clot easily, then we put you on a higher dose blood thinner afterwards. If it's someone who doesn't bleed enough, then we just watch you more with the tranexamic acid, which is a clotting thing we use. Yes?
You mentioned meloxicam.
Yes.
You send them home with that?
Yes.
What, you're already out?
I usually send them home on that. Most people that have knee replacements have some, most people that have knee replacements are 50, 60, 70 years old, so their kidneys aren't quite as healthy as they were when they were 20 or 30 years old. So meloxicam is mostly filtered out by your liver, instead of your kidneys, and most people don't have liver disease, so that's why I use meloxicam after surgery.
So if you have the surgery, then can you go off the meloxicam eventually?
Yeah, the goal is to get you off all the things you were taking beforehand. Yes, the Tylenol, meloxicam, Celebrex, whatever. Yes. Yeah. Yes.
Is there any danger if you're older to have any anesthetic?
So is the risk factor older for people as they get older? Octogenarians, people 80 and older, have a little higher complication rate with surgery. Usually not much. So, that's a great question, and that comes down to how bad do the knees hurt. And if it's keeping you from doing things, I know if it was my mother and she had bad knee arthritis, it was keeping her from walking and doing things, I'm like, well, it's probably an acceptable risk because the sedentaryism, the not doing stuff because your knees hurt so bad is probably worse than the risk of surgery. In my mind, but that's, yes.
To what extent is this surgery life-changing? In other words, do patients come to you and say, my God, you really changed my life. I am so thankful that I had this done, that, I'm a different person because of the knees.
So after surgery, do people like me, in other words? At 3 weeks, no. By 2 months, yes. By 2 months, most people feel better than before. By a year, they usually said they wish they would have done it sooner. Yes?
See anything coming in the way the medical insurance is going that says if you maybe you ought to do it now rather than wait because later they won't let you do it?
Is there any changes with insurance that will make you do it sooner than later? Probably not. I wouldn't let that be your only reason to have knee surgery. Yeah. Yes?
What about medical advances?
Any medical advances that will prevent knee surgery? None that I'm at all aware of. Like I said, some of the higher demand people, I use a different kind of plastic now. But that's probably been the biggest advance that's going to happen for probably 10, 20 years or more. Yes?
If you're in a foreign country and you get knee trauma somehow, what should you do?
So if you're in a foreign country and you get
hit by a car and bust your knee.
it depends on how rural the country. If it's Europe, where they're still well-trained orthopedic surgeons, you're good. If you're in an African country where your doctor doesn't know much, then you're as long as you don't have any open wounds, then I would get home as soon as possible. Or get somewhere that they know how to treat you as soon as possible. Yes. Yes.
This is a question related to what he said. What's your experience, if any, with these medical tourism, where you see reports and things that I went to Thailand and had this special surgery done and it was so much cheaper and same quality as here, et cetera.
Yeah, I mean, again, most people out of pocket for surgery, and I'm not sure exactly what it is, it's probably not too devastating. If you go here, you have someone to follow up with, you have someone that knows you, so I probably wouldn't encourage you to do that. We have had some people from other countries come here to have knee replacements, but yes. How soon can you travel? As soon as you're comfortable getting around. So most people are off a walker 3 to 6 weeks. They're probably not going to want to travel much before that time. So it's variable. The people who get off at 3 weeks, by 6 weeks they're able to, sure. Yes?
Following on that point, what do you see with your total knee patients in terms of getting their strength back and getting back to normal? Getting back to maybe playing golf, or when are they out of PT? You talked about that, they do that in a couple months. When do they get back to being?
So when do people get back doing things they want to do? Usually by 2 to 6 months, they're starting to do things that they could do before surgery, or even things that they couldn't do before surgery. Like stairs. Stairs are a big thing. People avoid them because it hurts so much. But usually by 2 to 6 months afterwards, people are going back to stairs, and they're able to start going up reciprocally now. And golf, golf is a very common thing. People ask, when can I play golf? As soon as you're comfortable. As soon as you're comfortable getting on a box, then go ahead and go to a range, hit some balls, and see how it feels. And yes.
How many years have you been doing surgeries?
I've been in 14 years, almost 14 years of practice. Yes.
Is it beneficial for people with frequent knee pain to stand more often than they sit?
Tough question. Is standing more painful than sitting? Usually. If people have to stand a lot, then your knees will condition, whether it's your native knee or a replaced knee, your knee will condition to what you want it to do. So if you want to be able to stand at your job 10 hours a day after knee surgery, then that's something you should train yourself to start doing. And so by the time you go back to work half a day, then 3/4 in the whole day. So yes.
I have a question about the meniscus and the kneecap. When you replace the knee,
Yes.
are either one of those?
So the meniscus we take out with the surgery because you don't need it anymore. And the kneecap usually has a lot of arthritis in it. So we trim it off. See, right here is a kneecap. You can see we've trimmed it off here. And again, we've taken off the worn off part and we put a plastic button right there. That's what that black thing here, that black space there is plastic. So we resurface the arthritic kneecap. So you keep your kneecap, which is this bone here, but you just put a button on it, the plastic button instead of the worn out cartilage. Correct. You can kneel after knee replacements, yes. Yes?
When you do bilateral knees, do you do both knees, or do you have another doctor on your team do that other knee simultaneously?
So if you have bilateral total knees, how is it staged? That is dependent on who is with me. I work with senior level residents, chief residents. Chief residents that work with me get a little bit of, they start doing more and more things as they've proven to me that they're competent, and if they're able to do it on my mom, so I usually go back, if I can trust them to do it on my mom, then I can trust them to do it on one of my patients. So sometimes there'll be a person that'll have bilateral knees, where I will do one entirely myself, and then I will help him or her do the other one. But it's usually staged somewhat. So it lasts a lot longer than just one, because we do the one and then.
That's what my mom had done, and she had that done. It was a doctor off of this individual's team, so one did one. As soon as he did that, he did that. So
Yes. Yes. Yes.
Do you ever have any situations where you have to have blood transfusions or anything?
So what's the blood transfusion rate after total knees? We started using a medicine called tranexamic acid about 2 years ago, and I don't think I've transfused a primary total knee since then. So our transfusion rate is very low.
What does that medicine do?
Tranexamic acid helps the fibrinolysis, so as a clot forms, there's also part of your body that's tearing down the clot. It blocks that, so it lets the clot form. I usually give one dose right when I'm closing, and then we usually use a tourniquet in surgery. So right when they get the medicine, then I let the tourniquet down. It rushes to where the knee is, where I want it, and then that's usually plenty to keep it at bay. Yep.
How long does the surgery take?
My average time for beginning to end is 52 minutes. Some take a little longer, some take a little shorter, but that's average. So, that's not counting setup. We got to put the tourniquet on, got to get the bumps in the right places, and then we got to take prep and drape. So we got to clean the leg, got to put the sterile drapes on. Then I do my work, and then we put the dressing on and take everything back off. So, yes.
So you said that you used an epidural for the surgery. Is the patient?
The patient's as awake as they want to be. Most of them don't want to be awake at all.
That's what I was thinking, because I'm not sure I want to hear this.
I have had people talk to me.
Okay.
There is the screen is up, the ether screen, old time called the ether screen is up. So, but yeah, most people don't remember anything. They go, I don't want to know anything, and they don't. Exactly.
Okay.
A lot of people don't even remember before the spinal.
Okay.
Do you use Versed?
Yes. Yes.
What kind of dressings do you use after the surgery?
So dressing after the surgery, we do all our suture under the skin. Then I usually put a piece of tape with Dermabond on top. And then I use a silver impregnated dressing on top.
Like Mephiles?
Exactly.
Now, what's the purpose of silver?
Silver has some antibacterial properties. So that usually stays on until they come back and see us 2 weeks later.
I thought maybe it just makes them feel better.
Oh, yeah, I got gold and silver. No. Yes?
How do you get the length right in comparison to the other leg, so that your back's not going off balance?
Great question. So how do you make sure that leg lengths are equal? We keep the collateral ligaments. So usually in a varus knee, this ligament's still the normal length, so we balance this side to equal that side. So people with a varus knee are usually feel short ahead of time. They're not necessarily short, they're just crooked and worn out. So when we get them straight again, they're like, oh, I feel longer. They're not longer, they're just straight again. Other questions? Yes?
Would you stay here till 10 o'clock if we kept asking you questions?
Probably. My wife took care of all the work at home, so. All right, you guys done well.
Thank you.